why don't we go ahead and get started? Patty is under the weather and wanted me to keep her from touching anything important, so we want to do that public health service thing. We'll start with that. So I'd like to welcome Jose and Hattie. Thank you for having me. It's great to be here.
Thank you for being here.
Yeah, it's good to be here. So what we wanted to do, why don't we go ahead and rapidly go around the room and introduce each other and ourselves. And so I'm Al, I'm a CMO of Mercy Medical Group here in Sacramento.
I'm Susan Ivey. I'm at the School of Public Health at UC Berkeley and a family physician in Berkeley.
Hi, I'm Lisa Albers, a medical consultant with the Department of Healthcare Services.
Hello everyone, I'm Emily Amarnath, also a medical consultant with the Department of Healthcare Services.
Hi, I'm Michelle Ballou. I'm a project manager with Hill Physicians.
Good morning, Deb Robertson, Regional Director for Hill Physicians here in Sacramento.
Kristen Robinson, I'm the Chief of Communications Management for Kaiser.
It might just be my hearing, but can everybody just speak up, please?
Take the microphone.
Susanna Ruby, I'm Director of Operations for Southern Independent Physicians. Hi, Jan Vandermeer, Director of our Care Management Programs for Sac-Sierra Region for Southern. Joan Werblin, retired PCD nurse, and I'm now Vice Chair of California Health Collaborative Board of Directors.
Katie Graff, I'm the Managed Care Coordinator with the California Primary Care Association.
Jacqueline Weiss, I'm a Regional General Manager for Genetic.
Tom Forster, Chief Medical Officer with Healthcare and Medical Director of for Health.
Dan Coverty, Account Manager with Barringer Eagle Line.
Good afternoon, Sarah Brass, and Chief of Staff's Office with the Northern California Healthcare System.
I'm Shelley Bolton. I'm Senior Account Manager for Nova Nordisk.
Mike Cooper, I'm a family physician and Medical Director for Managed Care at UC Davis, as well as the Assistant Medical Director of the Primary Care Network.
Hi, my name is Marshall Richardson. I'm a full-time student at Sacramento State University. My major is sociology. I'm an intern here for Warren for Grace Presbyterian Church. And my major is sociology. My concentration is behavioral studies.
Warren Burns, UC Berkeley School of Public Health and Grace Presbyterian Church here in Sacramento.
Kristen Talbot, Chief of Medical Staff at David Grant Medical Center.
Leonard Fry, LWF Home Care in the Bay Area in Sacramento.
Bill Remack, California Chronic Care Coalition and California Hepatitis C Task Force.
Roy Schultz-Simon, I'm the Chief Strategy Officer at Elka Health Center.
Jessica Nunez de Ibarra, Director of Coordination for California Wellness Plan Implementation at the California Department of Public Health.
Jerry Jeffy, California Chronic Care Coalition.
Hi, good morning. I'm Jennifer Byrne, an analyst at the Department of Healthcare Services.
I'm Toni Colley-Perry. I'm an educational consultant for Nesta College, Educational Resources.
I'm Sharon Chandler, Executive Director of Yesta College Education and Health Resources. And we have an African American Women's Health Legacy Program for diabetes and hypertension, and also a Minority Health Mentors Program for minority students who want to become health professionals.
Hi, I'm Cindy Snellgrove, Director of Clinical Services at Ampla Health.
I'm Charlotte Parker, and I'm a student practice coach, and now part of Dr. Bertol's team.
Hi, Yvonne Rodriguez, Sacramento County Public Health.
Hi, I'm David Ireland, Medical Director at Molina.
Eva Krishnovich, Senior Director of Healthcare Delivery for United Care Health. We're a Taft-Hartley nonprofit representing unionized hospitality workers across the country.
Linda Blake, I'm Supervisor for Care Coordination at UC Davis.
Hi, I'm Juliana with the Pharmacy Department at UC Davis.
Hi, I'm Stan Learn, Clinical Lead for
Truckle, I'm a pharmacist and the director of the Advanced Pharmacy Practice Program. Program manager for
Hi, my name is Sean Atha. I'm actually the Vice President for Network and Business Development with River City Medical Group.
No, they don't get off.
Good afternoon, Mary Ferguson, the Chief Medical Officer of Health Services Advisory Group.
I'm Tom Baldwell. I'm the Medical Director for Health Management and Education and Patient-Centered Medical Home Transformation, and I'm on faculty and family physician right at the Medical Center, Family Medicine, Community Medicine Department.
Hattie said she doesn't want to touch this, so this is Hattie Hanley, who everybody knows, and she helped create both Bright Care here at Sacramento as well as in San Diego and in LA. School of Public Health in Berkeley, Office of Patient Advocates, and all around community activists. So, thanks, Hattie.
And the Department of Managed Healthcare.
Department of Managed Healthcare, yes. And I'm Jose Alberto Arevalo. I'm a family physician locally here. I'm the Senior Medical Director at Southern Independent Physicians, and really excited that this program and the nice participation that we're having today.
Don't let them sit down.
You're first.
Just introduce yourself.
Okay. Talk about continuing this part. Olivia Casiri, Public Health Officer for Sacramento.
Hello, I'm Angela Rogers. I'm a fourth-year medical student at UC Davis School of Medicine.
So, let's see, you're going to help me find one. So, we have Mary Ferguson to blame for this today because we were talking, I think, 2 meetings ago, and she said, we're thinking about developing a survey for the MAs. And I said, okay. And I have the ability to go to SurveyMonkey and figure that out pretty quickly. What I did is wanted to use Planck 1 and measure our pressure down as the kind of gold standard for how to take a correct blood pressure, and survey the medical assistants in our group to see what I found. And again, I don't know what I don't know, so it's always worthwhile to ask. Our group is about 380 providers spread over the Sacramento metro market. We have about 20 primary care sites. And if you look at, we have about 85 hospitalists, about 70 PAs and NPs, and then we have the rest of our physicians are split between primary care, medical specialties, and surgical specialties pretty much evenly. So that's a little bit of background on that. So I wanted to do this survey based on measure pressure down. I developed 21 questions, and I sent it to 3 subgroups separately because I wanted to be able to do a subgroup analysis to see if there are any material differences. So the responses, primary care, medical specialties, and surgical specialties, a total of 101 responses. This is about a 40% response rate across the group. So I'll start with question 1. On a regular workday in the clinic, about how many times a day do you take the patient's blood pressure? What you notice is an impressive spread, really, where most physicians that are in the office are going to have more than 15 patients. And you have some people that rarely take blood pressure, and that's a problem of the first order right there. And it goes to, I think, blank number 3 in measure of pressure down. On what percentage of patients that you check in room do you take their blood pressure? Again, another way to get after this. This looks a little better because all of the other responses were basically 100% of the time. So you can really add the greater than 90 of the other together. But still, there's a number of people that don't take blood pressure very often. Or often enough, I guess is a better way Question 3, when you're taking a patient's blood pressure, do you ask them about consuming caffeinated beverages or smoking prior to taking their blood pressure? This is important. It should be asked every time because the ideal is to wait about 20 to 30 minutes after they've had caffeine or nicotine. So if you take somebody's blood pressure right after they came out of the parking lot and smoked a cigarette and had their Starbucks, that's going to be a problem. So it's rarely asked. When taking a patient's blood pressure, do you or the patient talk to each other? This is a big no-no. You're not supposed to. It raises the blood pressure. So there's a number of folks that do talk, or the patient talks, and ideally you wouldn't do that. So one of the things about all of these things that we're finding, every one of these is going to artificially raise the patient's blood pressure reading. So every dang one of them, it's not going to lower it. They're all going to raise it. So I've had my blood pressure taken a number of times in a variety of doctor's offices. I've never had these things done. Right? Do you round the systolic and diastolic blood pressures to the nearest 10? Rarely. Actually, it's much more frequent than this self-report when they're taking an annual blood pressure with a mercury sphygmomanometer. When was the last time you received formal training? A lot of people, it's been more than a year, and a fair number, 25%-ish, it's over 4 years. Where do you usually take the patient's blood pressure during the check-in process? In the hallway or in the exam room? Fortunately, most of it's in the exam room. That's where it should be, with the door shut. I can imagine what you're going to get in a noisy hallway, though. How's the patient normally positioned during the blood pressure measured? Now, just an aside, our director, or VP of Quality, actually asked her nursing directors to do an observational study, and they observed about 20 different patients. What they found is that while they were seated in a chair in the exam room, which is the right thing, their legs were almost always crossed. You're supposed to have both feet flat on the floor. So, seated in a chair in the exam room is the right thing. Where are the patient's feet? Both feet on the floor. They're over-reporting this. This is not accurate, I don't think. I think it's much more likely that they have crossed legs or they don't have both feet flat on the floor. On which extremity do you normally take the patient's blood pressure? It varies from arm to arm. I suspect that this is exam-room dependent to a certain extent. Which side is the table on? I don't, there's some evidence that maybe taking a blood pressure on the right arm is a bit more accurate, although I don't think logistically that's always possible. If you take a patient's blood pressure on their arm, what's your preference as far as the position of the patient's arm during the blood pressure reading? Arm hanging, shoulder level, support the arm on the exam table if they're lying down, and other. Virtually all of the other responses where the arms was supported at heart level, so you can put the support and other together, and you're probably going to get somewhere near 80%, which is pretty good. But that's right, you want your arm supported on the table, preferably at heart level, every time. How long do you usually wait before the patient sits down before taking the blood pressure? The observational study showed that they don't wait at all. They sit down and put it on. Ideally, you want them to wait 5 minutes. And somebody said that, maybe it was last time, 2 months ago, what my physician once told me is, when you're waiting, go to the beach. That is, mentally relax. Right? You're going to get a more accurate reading if patients really do relax before the blood pressure is taken. Oops, wrong man. What percentage of the time does the patient roll up their sleeve and get their blood pressure in their arm measured as opposed to having a bare arm? A lot. So 100% of the time, 70, 50. Ideally, you need to have a bare arm. You can do it, with the sleeve rolled up as long as it has no constriction. Lots of people take it over the shirt. Do you use a manual mercury manometer or with a stethoscope or an automated blood pressure cuff when taking the blood pressure? 50-50-ish. And some hallways have both. How many different blood pressure cuff sizes do you have? You really should have normal adult, large adult, and thin adult. Some offices should have thigh, child, of course, family medicine, pediatrics, of course. But for adults, you really need all three, and we seem to really fall down as far as than adults. And there are lots of people that will get a more accurate reading from that cuff. If you use automated devices, how many different models do you deal with? Often there are many different models. That isn't as important with the automated devices because we have them calibrated regularly. A lot of people are aware that actually we do calibrate them on a regular basis, although it's after hours. What percentage of your patients you think of blood pressure cuff at home and monitor their own blood pressure? This is very similar to the survey that I did in December with the physicians. I think about 50%, maybe a little bit more, have a blood pressure cuff at home. But they've never brought in who use it. So again, of the people that have it, I think it's variably used, and that's exactly what the physicians thought. And then, do you ever have them bring in their home blood pressure cuff to make sure that they're using the correct technique and that it's calibrated and is accurate at any level? So no, they rarely do that. So while lots of patients may have a home blood pressure cuff, it's never been, they've never had somebody observe them to see that they're doing it correctly. So there's opportunity afoot, and lots of it. So the other observation, as far as part of the observational study, is that when they were using a mercury sphygmomanometer, invariably they were reducing the pressure way too quickly to get an accurate measurement. So there's really pretty good evidence now that the automated blood pressure cuffs, as long as they're calibrated regularly, are actually a more accurate version. It gets over the rounding error, right? And so we're going to go to all automateds for our group. So blood pressure is checked very often by the back office staff. We're not doing it 100% of the time, and certain specialties like orthopedic surgery do it rarely. There are a number of knowledge gaps in what they should be doing as far as taking an accurate blood pressure. Smoking and caffeine question, talking during measurement, rounding, seated in the exam room with their feet flat on the floor with their arms supported, waiting 5 minutes, don't roll up the sleeve, have a bare arm. Multiple devices to contend with and not enough thin adult cuffs. Unclear on the calibration of all devices. I've been reassured that actually all of our automated are calibrated. So 40 to 50% of patients have home monitoring devices, but nobody knows if they're used regularly or if they're used accurately. And it's unclear if they're accurate in the first place. So, and the training for a lot of our MAs has been a long time ago. So, other than that, we're just cooking. Yes. It's just great. And I strongly suspect that there are certain things that are probably, it's like their feet flat on the floor. They know that that's probably the right answer, but didn't answer it that way. And the observational study shows that a lot more people with their legs crossed and feet flat on the floor. So my point, we had our quality committee meeting on Friday. My point is that if we can take a more accurate blood pressure, we'll look better. Because everything that we're doing wrong artificially elevates the blood pressure readings that we're getting. So we'll look better if we just do it right. So one of the objections for the medical and surgical specialties, particularly surgical specialties to measure, is that the surgeon or the specialist doesn't know what to do with it. Well, task the PCP. No, you don't have to treat it. Just make sure the information gets to somebody. So if you really have a blood pressure that's significantly out of range, tell somebody about it. Just raising the awareness in the MAs and having that pass back to the PCP is a huge opportunity. Every touch of a patient, we should have a blood pressure. So I went online and looked at a number of training videos. And if you ever want to put yourself to sleep with something that's as dry as dirt, watch some of those because they're impressively dry. So I think that, and there may be videos out there that are really quite good that address all of the planks. My guess is that there isn't, but I don't know that for sure. But why not do a training video that 2 to 5 minutes long, have everything in a state watching. That's it. That's the intervention right there. And try to get everybody on automated cuffs. And we will start to address finding people that need to be addressed better. And we'll have a lot more I don't think that these are hard things to do. It's just how do you get people to remember to do them? So my idea was actually we should have a really funny video, like the MA asking the patient, have you had any recent nicotine or caffeine, and they're smoking a cigarette and have a Starbucks cup in their hand. You know, I mean, that kind of dumb thing. But that's what would make it memorable. Because what I viewed is completely not memorable and is really really hard to watch. So, comments and questions?
I'd like to read.
Yeah. Oh, the other was, yeah, your feet are supposed to be flat on the floor. We'll have somebody that can do yoga and put their feet behind their head when that question is. So, you know, just dumb stuff like that to make it memorable so that, you know, it isn't so tedious to watch. It would be fun to watch. And you're going to remember these elements in it. You know, people, humans are genetically adapted to storytelling and hearing stories. And that's what makes things memorable for us. Reading bullet points like this, nobody remembers any of it. And that's what's been shown. So if you ever want to read a good book, read a book called Beyond Bullet Points about how to do PowerPoint presentations. It's absolutely great. So,
great presentation, thank you. My question is, as you pointed out, all of these errors in obtaining blood pressure are falsely elevated. I was wondering if you have any data to say how many patients were misassigned the diagnosis of hypertension and started on medications or other intervention, because that to me is the clear biggest negative to this. Yes, you'll bring your numbers down when you do it correctly. You may even think you're treating patients and bringing what you diagnose as hypertension falsely down. But when we start doing invasive things, including giving medications, it's really
risk of harm. Absolutely. No, I agree with you. We're probably harming patients. And this may be why JNC8 for the people over 60 went to 150 over 90. It may be that we're actually over-treating patients because we're not reading their blood pressure, taking their blood pressure correctly. So your point is a really good one. You know, I mean, primum non nocere, right? Above all, do no harm. You can harm people with antihypertensives, and that happens all the time. So how do we take an accurate blood pressure and treat the right people? That's what it's about. So I agree.
So I was interested in the thing about using the bell side of the stethoscope instead of the diaphragm, because I'm pretty sure none of my MAs or nurses have a stethoscope that has a bell. They only have a one-sided.
Right.
You know,
the
it's
diaphragm.
the least expensive.
Right,
you know,
and that's the other thing that, as far as taking an accurate blood pressure. In the observational study, they looked at the MA stethoscopes, and they're all terrible. You know, they're the cheapest things, but yes, the bell side is the recommended side. You don't get the crop cuff sounds because the lower pitch crop, you don't hear them with the diaphragm. And that may be why, again, another reason we're overestimating what the blood pressure is.
I just remember in medical school how much better my murmur diagnoses were after I got a Littman cardioscope.
Yeah.
You know, we can't buy a Littman cardioscope for every MA.
No, but you buy an automated blood pressure cuff for every office. That's how you get, and again, the literature is pretty good that you should go to automated because you're going to get better. And so what we really like to have is a biomedical device that can automatically populate the electronic medical record in the right place so that there takes a human error of rounding or transcription or any of that stuff out of it. And if we can do that, that would be great. So, yeah, go ahead.
I was wondering, since you're having all these difficulties and it's in English, if you're addressing, you know, the language obstacles, you know, that in, you know, taking care of correcting for the future?
So again, these are the MAs that are our employees, or the employees of the foundation is a better way to put it. And so as far as the language barriers of getting the patients to do these things, I didn't ask those questions, but it's a good question because, again, being sensitive to helping them understand that they need to relax for 5 minutes and that they need to have their feet flat on the floor. And they need to understand that that's for your benefit as a patient, so I can get a good reading. We're going to be culturally challenged unless we can really speak the language or have appropriate interpreter in the room. So, yeah. So yes, getting patients to be on board with this stuff too. Like, sit down, relax for a few minutes, go to the beach, just relax. I don't want you on your iPhone. I don't want you texting. I don't want you to do any of that. You need to relax. And that's how you're going to get the most accurate view. Yeah, I'm sure patients are going to be texting. So, other questions?
How are you using it to change what you're doing? Are you going to all of them?
Yeah, so action steps, so we are going to go to all automated. We are going to ensure that we have the correct sizes of the cuffs in all the hallways. We're going to now insist across the group that every visit the patient gets a blood pressure check, no matter what specialty. And if an elevated reading is found, then that goes to the primary care doctor. The specialist doesn't have to deal with it. And we're going to draw some levels and say, what's a real, call everybody and their dog, or call, text the or task the PCP. We haven't come up with that yet, but we're going to figure that out here in the near future. So, but we do need to train the MAs, and there's not enough trainers to get this done in a very short order. So I think that doing a video and making it funny and 2 to 5 minutes long, it's asynchronous. People can watch it on their own time. They'll enjoy watching it, that kind of thing. I think that that'll be our training. And honestly, I think that this is a huge opportunity for the group to get accurate blood pressures and treat the right people.
I just have an observation, question, whatever. Are you getting buy-in from the people, the hierarchy who's running these clinics?
Yes.
I know where I get my health care, it's a very busy clinic. There are 1 or 2 MAs who are responsible, each one of them, for maybe 4 rooms. And vital signs are done in the hallway at the vital station where you're weighed in, your blood pressure is taken. Sometimes they do that because then they can get ahead and then you're asked to go back out to the waiting room and sit down. I ended up on hypertension pills, so I don't know if I'm really hypertensive or not at this point.
You are thinking about that.
As a nurse, yes, I'm thinking about it a lot. But, there's this push to move people in and out. Everybody's over-appointed. The time you get to spend in that examining room seems to be getting less and less. So, they're not going to take you in there and let you sit for 5 minutes. It just doesn't happen. So how are we going to reevaluate how we do business?
Yeah, so indeed, everybody from the highest level has bought into this. Our board of directors, the executive vice president for the foundation, Sigrid Boyang, and VP of quality, VP of compliance, and all of the directors underneath them have bought into this. They were at a meeting on Friday. They agree it's absolutely the right thing to do. If you look at our operational priorities in order, patient safety, human kindness, clinical expertise of whatever you do for the group, and then productivity is last. If we don't do this, we're not even meeting basic patient safety, right? Because we're getting inaccurate readings and we're not finding the right people and treating the right people with our risk of harm. So if you look at how we think about things now, it absolutely goes to our basic level of patient safety. We've got to do it. We've got to figure out how to do it. We've got to figure out the workflows how to do it every time. So, thanks.
Yeah, thank you, Alan. That was an excellent presentation. And, great work you do. And this is the second of surveys that Alan has put together. We're now promulgating the first one, which is based on getting clinicians' understanding of some of these similar issues. And we're trying to continue our promulgation across the capital region, and also hope to work with CAPG and make this the Girdle survey a statewide known product that's really going to help us improve care across the state. Great work, so exciting. Well, now I have the privilege, excuse me, but before I do, I wanted to kind of remind people that next month, July, we'll be celebrating our 2nd year as the Capital Region Right Care university best practices and continuing to have great participation. And again, what we're trying to do here is to share best practices across the region and what we say, leave the swords at the door, come here and really work toward improving the care that we provide, cardiovascular care that we provide in our region across all our systems that include the county and include the community clinics and include, the community pharmacies and skilled nursing facilities, as well as the VA and the 4 large regional systems, because we really want to be as inclusive as possible. And so it really is a really great activity that we are put together here, and I feel very fortunate to continue to be here and celebrate our 2nd year next month. So thank you for being here and continue to participate. And again, we really want to thank Sierra Health Foundation for the great support that they provide us, as well as Health Services Advisory Group and Mary Firmison and some of our other partners who have really contributed significantly to the success of this Right Care program. But now I'm really excited to introduce Tom Balsbach, and I've known Tom for a while, and when he was a residency director at UC Davis Department of Family Practice, and did a great job there, and now has moved on and is the director for the patient-centered medical home. Oh, do you want to do?
So what we can do these guys do?
Oh, okay, all right.
So,
sorry.
Pause.
Yeah. So we're going to introduce, and again, they need no introduction. We're going to move forward with a hypertension update with Mary Firmison, who, again, Health Services Advisory Group, the Chief Medical Officer, and Susan Ivey, who has done a really marvelous job she's our consultant, and she's from the School of Public Health and is a family physician and professor, and they're going to update us on some hypertension work that we've been doing. So, all right.
It's all right. I forgot too.
Also gives us a chance to say, as we're getting close to July, I was saying on the way up to Amanda, one of our students, that Hattie also always attracts to Right Care, how Jose has been with us from the very beginning. So 2 years anniversary for him too. And really thank you for your dedication to keeping this going. So we're trying to also have products that are useful to the medical groups that are coming. We didn't hear back from anybody last time, so I wanted to just put in a pitch again for our little algorithm. We now know that we are going to be able to have some help from the Medi-Cal division to do some printing of the hypertension algorithm. We've worked very carefully on our fonts the past 30 days, just so you know, so there'll be a legible pica for the elderly among us. And we have it into a 2-sided format where it's going to print on a card like the Gunderson cards that you guys saw 3 months ago. But I really need to hear back from the groups how they would disseminate this and how many copies that they want. So Mary's going to talk a little bit about what she has worked out with the LA folks, and maybe we can figure out good ways to get input from you on the number to print and stuff.
So we, aside from this algorithm, which should be available electronically, if you would like to have it electronically,